Hi, good evening everyone. This is Dr. Sowjanya, your surgery faculty from the Medicoz Community. So we are here to discuss the remaining questions from the first session where we discussed the first 12 important clinical questions from general surgery, and now we are here to discuss the remaining 13 questions. But before that, let me give you a brief introduction about the Medicoz Community. This platform we are offering courses for the next 2024 exam, so you can avail this offer, early bird offer from the Medicoz Community, where you can start your preparation right from the UG onwards or even in your internship period as well. So this will boost up your preparation levels and will help you attain your goals. So this is the timetable of the upcoming sessions which are going to be held live on the Medicoz Community platform on YouTube. Okay, I hope my audio and video and everything is clear so that I can proceed with the questions part. Let me know in the comment box if there is any lag or any audio disturbance or something like that. I hope it's clear for everyone. Yeah. Okay, let us proceed with the questions part. So the 13th question, which is, which of the following is incorrect about the subclavian steal syndrome? So what is he asking? Okay, let me take my pen. Yeah. Which of the following is incorrect about subclavian steal syndrome? Yeah. So what are the options? First of all, let us know what a subclavian steal syndrome is. The subclavian steal syndrome, for suppose this is a heart and this is your arch of aorta. Okay, let me change the color of the pen. Yeah. So this is your arch of aorta, and you can remember the branches of arch of aorta as A, B, C and S, ABCs. So this is your arch of aorta, from where you get this is your left side and this is your right side. So right brachiocephalic trunk, and then you have your left common carotid, and then you have your left subclavian. This right brachiocephalic trunk again divides into your right common carotid and your right subclavian. So these subclavian arteries, from these subclavian arteries you get your vertebral vessels, vertebral arteries. These two vertebral arteries join together to form your basilar artery. This basilar artery forms a part of your circle of Willis, which is like this, to the brain, and this to the heart, to the arm. So when you have this proximal obstruction, the blood is not coming this way. So the blood that is going like this is pulled up from this side. So this arm is basically stealing your blood from the opposite vertebral artery. So this is called as your subclavian steal syndrome. I hope everyone is clear with that. If you have any doubts, you can message me in the chat box. Okay. So let's see the options now. What is the first option? Most common causes atherosclerosis. So we are seeing the narrowing of the vessel. This is most commonly due to the atherosclerotic plaques. So this is a correct option. What is the second option? Reversal of blood flow is seen in contralateral vertebral artery. Here you have to see if he is asking the contralateral or the ipsilateral. But in our picture we did see there is normal blood flow in the contralateral, means opposite. So there is normal blood flow in the opposite vessel, and the stealing causing the reversal of the blood flow in the same side, the ipsilateral vertebral artery. So reversal of blood flow is seen in where? In the ipsilateral instead of contralateral. So this is a false option. Let us see the other two options. Option C, due to obstruction proximal to the origin of the vertebral artery. So here the origin of the vertebral artery is here and the obstruction is proximal to that. So this is also a correct option. And option D. Option D is what leads to vertebrobasilar ischemia. As we have seen that these two vertebral arteries combine and form the basilar artery and supplies the posterior part of the brain. If there is any obstruction, it is causing ischemia to this posterior part of the brain, which is called as vertebrobasilar ischemia, due to this vertebral vessels and these basilar vessels. So this is also a correct option. I hope it's clear to everyone. Okay. So let's proceed on to the next question. A 56-year-old female comes with complaints of lump in the breast. Complaint of lump in the breast. History of loss of weight and appetite. Loss of weight and appetite, as we spoke, indicating probably a malignant condition. Okay, so on examination, the breast looks as in the image. So what is this image showing? This image is showing the classical pudgy orange appearance of the breast. So this dotted appearance is there, no, which is similar to the skin of the orange. So this is called as pudgy appearance. Okay, what is he asking? True among the following. He is asking about the true statement. So let us go to the options. Option A, this is due to involvement of Cooper's ligaments. So this pudgy orange is due to what? Pudgy orange is due to involvement of the dermal lymphatics. The lymphatics in the skin. These are infiltrated and causes this pudgy orange appearance. This you have to remember. This is a star mark question. And these Cooper's ligaments, if they are involved, they doesn't cause pudgy appearance. Instead, they cause this dimpling and puckering. This is one of the questions that is repeated. You can see dimpling and puckering are due to Cooper's ligaments and pudgy orange is due to involvement of the lymphatics. Don't confuse between these both. Just remember. Okay, let's go to the next option. This is the most conspicuous sign of breast carcinoma. So, this is very classical sign of the breast carcinoma. This is correct option and this is a wrong option. Let's see what the third option. Triple assessment includes mammography, FNAC and CECT. What is this triple assessment? Triple assessment includes assessing like in three ways. First one is clinically. Your clinical assessment, which are your signs and symptoms. This pudgy orange, dimpling, puckering, ulceration, satellite nodules. All these your clinical assessment. Next one is your radiological assessment. This radiological is through mammography or ultrasound. Mammography or ultrasound comes under the radiological part. And the third one is your histological part. This histologically you will see it through FNAC or a biopsy. So what did he give? Triple assessment includes mammography, FNAC and CECT. But what are we seeing? Mammo is there, yes. FNAC is there, yes. But CECT is not a part of the triple assessment. Your CECT is not a part of the triple assessment. So this is also a wrong option. Yeah, this is also a wrong option. Let's go to the fourth option. Investigation of choice is mammography. In mammography is investigation of choice just for screening purpose. For diagnostic purpose, true cut biopsy or core cut biopsy is the investigation of choice for the diagnosis. For screening purpose, it's mammography. So this is also a wrong option. So what is he asking? He is asking the true statement, which is option B. Okay. Yeah. So let's proceed on to the next question, which is, yeah, what is the correct combination among the following? He is asking about the correct combination. So option A is calcium oxalate dihydrate, option B uric acid stones, option C calcium oxalate monohydrate stones, and option D cystine stones. So what are these? These are the renal stones and their shapes. So first of all, let us see what is the shape of this first one. Yeah. This first one is what? Hexene or benzidine shaped. Hexagonal shape or benzene ring like stones. So what are these? This is a six-sided, no? Six, you remember it as cystine. Cystine is six, it sounds like six, no? So this is for cystine stones. And what is the second one? This is like a coffin. They use for death, no? Like that. This is a coffin lid shaped stones. Coffin lid shaped stones which are seen in case of struvite stones. Struvite stones are coffin lid shaped. And what is this third one? This is showing, see, it looks like a dumbbell, no? Yeah. This dumbbell has two headed balls, like, no? So this is for calcium oxalate monohydrate. In that it has mono, but here it has two. So calcium oxalate monohydrate stones are dumbbell appearance. And what is this? This is a rhomboid shaped. Rhomboid. This looks like a U on a U, no? So remember it as uric acid stones. Uric acid stones. So let's see the options again. So what is the first option? Calcium oxalate dihydrate. Calcium oxalate di. This dihydrate has a single envelope like shape. Envelope is single, but it's for di. But for mono, it has two. So just remember like that. Calcium oxalate dihydrate are envelope shaped, but here it's given as hexagonal. So this is a wrong option. The second one, uric acid stones. Uric acid, we thought it as U on U, like rhomboid shaped. But here it's given as coffin lid shape. So this is also a wrong one. So option C, calcium oxalate monohydrate. For mono, we thought this dumbbell shaped. So this is the correct option. So this is our answer. Let's see the fourth one, cystine stones. This is for 6, the hexagonal shaped stones. So this is also a wrong option. So which is our answer? Our answer is the third one. Okay. So what are the other shaped stones that we can see? We can see this needle kind of stones. These are called as brushite stones. Brushite. Brushite is nothing but, you remember it as a brush and the needles on the brush. Okay, brushite, needle shaped stones. And there are other large stones like the staghorn calculi. These staghorn are nothing but the triple phosphate stones. These are made up of these 3 kinds of phosphate stones, which are nothing but your calcium phosphate, your magnesium phosphate, and your ammonium phosphate. Calcium phosphate, magnesium phosphate, and ammonium phosphate together forms your triple phosphate stones, which are your staghorn shaped stones. These occupy most of the part of the renal pelvis. So these shapes you should remember. He might ask one question from these as well. Okay, if it's clear, I'll proceed to the next question. Okay. So let's go on to the next question, which is all are true about choledochal cyst except. So what is he asking? The true statement about what? Choledochal cyst. So option A, Bosniak classification is used to classify choledochal cysts. What is a choledochal cyst first of all? Choledochal cyst is nothing but you have your liver like this, from which your gallbladder is attached. And from the gallbladder you have your cystic duct. From the liver you have your common hepatic duct, which together form your CBD, your common bile duct. You have your hepatic duct and your cystic duct together forming your common bile duct. So if there is any cystic lesion or cyst formation in the CBD, then it is called as a choledochal cyst. So let us see what are the options. Option A, Bosniak classification is used to classify choledochal cysts. What is the classification we use for the choledochal cysts? It is not the Bosniak classification. Bosniak classification is for what? It's for the Bosniak is for renal cysts. But for choledochal cysts, we have Todani classification. These named classifications you have to remember, but because he might ask like a match the following kind of question from these classifications. So Todani's classification is used to classify choledochal cysts. He's asking true except. See, you shouldn't miss this except. So this is a false statement. So this is our answer. So, but let's see the second option, which is option B. Liver transplantation is the treatment of choice for type 5 choledochal cysts. So first of all, let us see the types of the choledochal cyst. So these are the different types of choledochal cysts. Type 1 is nothing but what? First of all, what is this classification? It is Todani's classification. And what is type 1? Type 1 is nothing but a dilatation, a saccular dilatation in the CBD. CBD dilatation is type 1. What is your type 2? Type 2 is nothing but a diverticulum. Not just a dilatation, but there is a protrusion. The diverticulum is present. This is called your type 2 choledochal cyst. What is type 3? Type 3 is nothing but where does this CBD opens into? It opens into the second part of the duodenum at the ampulla of the Vater. Ampulla of Vater. The second part of the duodenum. So here if this intraduodenal part is dilated, then it is a type 3. 3D. You remember it as 3D. Type 3 is for intraduodenal dilatation. And what is your type 4? Type 4 you have 4A and 4B. So your 4A is for both intra and extra. Extrahepatic dilatation is present, and also within the liver also it's dilated. So extrahepatic dilatation and also your intrahepatic dilatation. What is your type 4B? 4B. 4B is your only extrahepatic dilatation. The intrahepatic it's on normal. So 4B is only extrahepatic. And your 5, this is only intrahepatic. 5 is only intra. And before this 4B is only extra. And 4A it's both. Combination of 4B and 5. Okay. So let us see it again. Type 1 is just dilatation. Type 2 is diverticulum. And type 3 is intraduodenal. 3D. Intraduodenal part. And type 4A. A is both intra and extra. 4B is only extra. 5 is only intra. Okay. So let's see the other options. What did he give? Liver transplantation is the treatment of choice for type 5 choledochal cysts. What is a type 5? Type 5 is nothing but only intrahepatic dilatations. So what do we need to do? We have to transplant this liver so that you can remove all these cysts. So liver transplantation is the treatment of choice for type 5. This is a true statement. In which other condition you will do a liver transplantation? You can also do a liver transplantation in type 4A. If he gave a question like liver transplantation is used in which kind of choledochal cysts, then you can go for both 4A and also 5. But if he is giving only one option, then you have to go for type 5. Okay. Yeah. So let's see the third option. Most common type is type 1 followed by type 4. He's telling that it's type 1 cyst is more common than type 4. Which is type 1? It's just a dilatation of the CBD. And type 4, you have your 4A, 4B. This is just all to revise. Okay. 4A is both extra plus intra. And 4B is only extra. I mean extrahepatic dilatation. So you just remember it as 1, 4, 3. Type 1 is more common, followed by type 4, which is followed by type 3. So you remember it as 1, 4, 3. So this is also a true statement. Option D, investigation of choice is MRCP. Investigation of choice is MRCP. This is true. MRCP is nothing but magnetic resonance cholangiopancreatography. Okay. So this is your investigation of choice. So our answer is option A, Bosniak. Bosniak classification is for what? Again, renal cysts. Okay, let's go to the next question if everything is clear. I hope everything is clear for you. Yeah. Okay, let's proceed with the next question, which is a 34-year-old man underwent an accident and had fractured his pelvis. So there's history of accident. Okay. And had fractured his pelvis. Pelvic fracture is there, accident is there. On examination, this blood at meatus. So what does this blood at meatus indicates? It indicates a urethral injury, probably a urethral injury. So pelvic hematoma is present. What is there? Okay, just pardon. Yeah. What is there? A pelvic hematoma. Urinary retention is also present. There's urinary retention which is also pointing up towards your urethral injury. So what is the most probable location of the injury? He's asking the location of the injury. So let us see. This urethral injury, we have anterior urethral injury, and posterior urethral injury. We have these two kinds of injuries. And in anterior urethral injury, what happens? When you're hit on from the front side, the pelvis gets fractured and that compresses your urethra and causes the injury. So these are mostly seen in case of accidents. And he'll give a history of pelvic fractures. Okay, but in case of posterior urethral injury, he'll classically give it as a straddle injury or your manhole injury. This you have to remember. He'll give it commonly as a man fell in the like manhole, like that kind of question. So first of all, let us see the parts of the urethra so that you'll get a clarity on where it is getting injured. So what is this? This is your bladder from which your urethra is arising, and there are your prostates here. So this is your prostatic urethra. You have your prostatic urethra, which is continuing as your, this is the membranous part of the urethra. And then this part is the bulbar urethra. This is the bulbar urethra. And whichever is present in this penile part is called as penile urethra. So you have 4 parts in your urethra, which is prostatic urethra, membranous, bulbar and penile urethra. So whenever there is an accident, what is happening? The force is coming in this direction. So there's pelvic fracture which is compressing on this membranous part of the urethra. Let me change the color for the clarity. Okay, yeah. So this is hitting and causing damage to the membranous part of your urethra. So in this membranous, this junction, the junction of the bulbar and the membranous is called a bulbomembranous junction or bulbomembranous urethra. This is most commonly injured than the prostatomembranous junction. So bulbomembranous junction is most commonly affected than the prostatomembranous. So this happens in case of what? An anterior urethral injury. But what happens in case of a posterior urethral injury? If there is posterior urethral injury, okay, yeah, what happens? Man falling on a like bicycle rod is hitting, something like that, in a manhole. This bulbar part is compressed. So what happens? Due to this compression of the bulbar part, bulbar urethra is most commonly affected in case of a posterior urethral injury. And what happens? Both the scrotum is filled with hematoma and also shaft of the penis is also involved. So this gives you a classic butterfly shaped hematoma. Butterfly shaped hematoma is seen in a posterior urethral injury. whereas just the pelvic hematoma is seen in case of anterior urethral injury. Okay, so what is he asking? Most probable location of the injury. Option A is membranous urethra. Where is this membranous urethra injured? In case of anterior urethral injury, which is in our case. So this is the correct option. Let's see the other options. Option B, bulbar urethra. Where is this bulbar urethra injured? Most commonly in a posterior urethral injury. So this is a wrong option. Option C, bulbomembranous junction. So see, this is why it's important to recheck your options, because membranous is also your answer and bulbomembranous is also the answer. But in the membranous part, bulbomembranous junction is most commonly affected. So when given between these two options, you keep this as your answer. But if it is a multiple option, you can put it both, or if he is giving only membranous, you can go for membranous. When he is giving both, you'll go for bulbomembranous junction. And option D, penile urethra, this is not involved. So our answer is option C. Okay, I hope this is clear to you. Okay, so let's go to the next question. Okay, what is this? A 24-year-old female comes with complaints of dysphagia. Dysphagia which is more to liquids than to solids. This point is very much important. Dysphagia is present to what? To liquids more than solids. So dysphagia to liquids more than solids. Why is this important? For suppose this is your esophagus and there is a mass growing on here. This is some tumor, esophagus carcinoma, something. So when you swallow your food bolus, this can't enter here. But when you have your fluids, they go easily. So in case of any tumors or malignancies, you have dysphagia more to solids. But in case of these spastic conditions and all those, you have dysphagia to liquids more than solids. So this is pointing out that it's probably not a malignancy. You can't exactly say, but yeah. So what did he give? Barium swallow shows the following picture. What is this picture showing? This is a classical, many times it has been repeated in your questions. So this is your bird beak appearance. Like this is the beak of your bird. So this is your bird beak appearance. So where is it classically seen? This bird beak appearance is classically seen in your Achalasia cardia. Okay, just ignore this is, yeah, seen in your Achalasia cardia. So the diagnosis for this condition is Achalasia cardia. What is the gold standard investigation and management to be done? He's asking the gold standard investigation and the management to be done. So first let us see what is the gold standard investigation for the Achalasia cardia. What is happening? There is inhibitory neurons are lost in a segment, in a particular, only just a selective inhibitory neurons are lost. So here also the lower esophageal sphincter tone is also affected, but that is more in case of a GERD. So first, the gold standard investigation is to see the spastic condition is there. You have to monitor the pressure there. Motility disorders, for motility disorders you go for manometry rather than a pH monitoring. pH monitoring, where will you do? In case of GERD, if the lower esophageal sphincter tone is lost, there is reflux of acid from stomach into the esophagus. So here you will monitor the pH for 24 hours. But in case of Achalasia cardia, which is a hypomotility disorder, the motility here is decreased. So here what will you measure? You will measure the manometry, the pressure. Is the pressure proper to like open up? So manometry is the gold standard investigation for this Achalasia cardia. So we have manometry in two of our options. You can eliminate the 24-hour pH monitoring, which is for GERD. This also might come as a question. So yeah. And what is the other thing? He's asking the management. What will you do? what are the options given? First, let's see. They are given as Heller's myotomy and fundoplication. These are the two options, no? So either fundoplication or Heller's myotomy. Fundoplication is what? This is your esophagus and this is your stomach. You take this fundus part of the stomach and rotate it around the lower esophageal sphincter, like the lower part of the esophagus, so that it is stiff, so that the tone of the sphincter is maintained. This is called as fundoplication. This fundoplication is done in case of decreased lower esophageal sphincter, which is seen in GERD. So this GERD, you'll do the fundoplication for GERD. And in this fundoplication, you have three types, which are nothing but your niscens, your dors, and topes. These you can remember it as 360, 180 and 270. 360, 180 and 270. Like you rotated the completely, if you rotate 360 degrees, then it is called niscens. If you rotate it half and leave it, then it is 180 and your topes is 270 degrees. Okay. So, but this is not in case of achalasia. In achalasia, what will you do? You'll do an endoscopy and you'll just do this laparoscopic Heller's myotomy. You'll just put a slit in the muscle there. So Heller's myotomy is the management for achalasia cardia, and manometry is the gold standard investigation. You have to remember this gold standard investigations. So option D is our answer. Here you have covered the questions for bird beak appearance, dysphagia motor solids, myotomy and pH monitoring, and also this manometry and myotomy. So let's move on to the next question quickly. A 20-year-old male comes with complaints of fatigue, tiredness, lack of concentration. So his complaints of fatigue, tiredness and lack of concentration. Lab investigations show hemoglobin 9%. In males generally, it is considered as a bit low, and stool occult blood is also positive. So there's blood loss which is leading to this decreased hemoglobin, which is leading to these symptoms. So endoscopy shows the following picture. What is this picture? This is classically, there are, you can see multiple number of polyps. So many numerous number of polyps are present in the endoscopic finding. So what is this condition? Usually these many polyps are seen only in FAP, which is nothing but your familial adenomatous polyposis. So here what is he asking? What is the management in this case? What is the management for the FAP? FAP is where you have more than 100 polyps in a one cross section. Okay, this is considered as FAP. And in FAP you have your what is the treatment he's asking? This FAP is just 1% like of the colorectal diseases. There is 1% of the colorectal carcinomas are associated with FAP, but if FAP is present, there are 100% chances to convert into a malignancy. So if there is FAP in a person, by 40 years, 100% it develops into a carcinoma. So what you have to do, you'll prophylactically remove all the like colon and the rectum, because those are the common paths for this FAP polyps to occur. So total proctocolectomy is done in case of FAP, which is also prophylactically. Before only you'll do it, so that you will prevent the conversion to the malignancy. So total proctocolectomy is the treatment of choice for FAP. Okay. Here you also have to cover the topics HNPCC, which is Lynch syndrome. This is more commonly seen, like more percent of the colorectal carcinomas are associated with HNPCC, but HNPCC has only 80% chance to convert into a malignancy, whereas a FAP definitely converts into a malignancy. So surveillance is enough for HNPCC, but total proctocolectomy need to be done for FAP. Excision and biopsy, if for a single polyps you'll do excision and biopsy, this is not the case. So Roux-en-Y is different for gastric masses and duodenal. For all those you will go for a Roux-en-Y. So let's proceed to the next question. 20. Also you have to cover Gardner's and Turcotte's which are variations of FAP, Gardner's and Turcot's. So there's not much time left to explain all this, so I'll give just a clue. For Turcot's, you remember as brain tumors are given. Turcot is a smart person, so brain tumors are in. If given, then it is Turcot's. If he just gave sebaceous cysts or these osteomas on the jaw and all, then it is Gardner's. These two are variations of your familial adenomatous polyposis. So what is the next question? All of the following are components of triangle of doom except. So let's see what is this triangle of doom. This is your triangle of doom. The apex is near the deep inguinal ring. So when you do your laparoscopic hernia operations, you might enter this triangle and rupture these vessels. So you should be careful when you're doing your laparoscopic hernia repairs. So what are these? The borders are formed by this vas deferens and this gonadal vessels. Gonadal vessels. Whereas what are the contents? It has this iliac artery, iliac vein, and also has your genital branch of the genitofemoral nerve. Your genitofemoral nerve has genital branch and a femoral branch. Okay, so the contents of this are iliac artery, iliac vein, and genital branch of the genitofemoral nerve. So you might damage these vessels, which might cause the person to go into shock and all. So it's the triangle of doom. You are doomed if you enter the triangle and cause rupture of the vessels. So basically, just lateral to this triangle is your triangle of pain. Triangle of pain, where these gonadal vessels form the medial boundary for this. For this, it's lateral, and for this triangle of pain, they are the medial boundaries. So when you place a mesh in these hernia operations, this the top part is formed by the iliopubic tract. So you shouldn't place your mesh below this tract to avoid injury to these nerves. There are nerves in this triangle which, if you injure, might cause severe pain. These are the femoral nerve, and these two are your femoral nerve, and this is your femoral branch of the genitofemoral nerve. The genital branch is present in triangle of doom, and your femoral branch is present in your triangle of pain. So femoral branch of the genitofemoral nerve, what are the other two? These are the lateral cutaneous nerve of thigh and anterior cutaneous nerve of thigh. Lateral cutaneous nerve of thigh and anterior cutaneous nerve of thigh, which supply the sensory supply to the lateral part of the thigh. Okay, there are also these deep circumflex iliac vessels. Deep circumflex iliac vessels which run around the lateral part and supply your thigh part. So remember the contents of the triangle of doom and the triangle of pain and their significance as well. So what is he asking? All of the following are components of triangle of doom. Triangle of doom is your medial one. This like this. Your pain is the reverse triangle. So what are the contents of this? As we already spoke, iliac artery, iliac vein, and your genital branch, not your femoral. Your femoral branch is present here, and your lateral cutaneous nerve and anterior cutaneous nerve. So iliac artery is present, yes. Iliac vein, yes. And the femoral branch of the genitofemoral. Femoral branch is present in what? It's present in your triangle of pain, not in doom. So this is a wrong option. He's asking except. So this is our answer. And the genital branch, yes, our genital branch is present here only, no? So this is our next question. Yeah, let's go for the 21st question, which is endoscopic picture of 28-year-old female with upper GI bleed. So a younger female, upper GI bleed is present. What is the type of the ulcer and risk associated with it? So the endoscopic picture is showing you an ulcer inside, peptic ulcer, which is, how is it? It is seen as a dark black clot. So what is he asking? He's asking the type of the ulcer and the risk associated with. So this upper GI bleeding, this peptic ulcer upper GI bleed is classified by the Forrest classification. What is the name of this classification? Forrest classification. So there are three classifications we have seen in today's session, which are Forrest classification for, this is to assess the rebleeding. You'll do the endoscopy and you'll see the ulcer and you'll assess whether it's going to rebleed or no? For that you use this classification. Forrest classification for upper GI bleed, and we have seen Bosniak, which is for renal cysts, and we have also seen Torani's classification, which is for the choledochal cysts. So remember all the three. Okay, so according to this classification, where is this ulcer being classified and what is the risk? That is what he is asking. No? Let's see the Forrest classification. So 1A is nothing but there's forceful arterial bleed, like it's coming out like a gush. So arterial spurting. You can also see the pulsations here because it's an arterial bleed and it's pulsating and it's pushing out the blood. So arterial spurt is your 1A. And what is your 1B? 1B is oozing from the ulcer bleed. See, there's ulcer here and the blood is coming out, but it is not coming out like a spurt. There's no forceful ejection. So this is your 1B. And you have your 1A, 1B. You have your 2A, 2B, 2C. And in 3, you have only 3. 1, 2, 2, 3 and 3 is 3. So in 2A, you have your vessel is visible, but there's no bleed. If there is spurting bleed, it's 1A. If there is just an ooze, it's 1B. And blood vessel is present, but there's no oozing or there's no gush, then it is 2A. What's your 2B then? 2B is the clot, the adherent clot. There is a bleeding has occurred, but clot has formed. So it's your 2B. And 2C is the black spots. Black spots can be seen, but there's no clot or there's no bleeding. That is your 2C. And what's Forrest classification 3? It's a clean ulcer base. See, the ulcer base is very much clean. There's no oozing. There's nothing present there. So it's your class C. So what is this? This is your adherent clot. So this comes under what? Type 2B. Your clot is the type 2B. So not this, not this. So he has given 2B in 2 options. So you have eliminated 2 options already. So what is type 2B and what is the risk you have to see? So type 1A and 1B, these both have high risk of rebleeding. There are high chances of rebleeding because there is like fresh bleed is present already. And 2A and 2B are associated with intermediate risk of bleeding. This 2A and 2B, because there is fresh clot and there is vessel visible, these both have intermediate chances of rebleeding. And 2C and 3 they have low chances of bleeding because there's no ooze, there's no clot, nothing. So yeah, what did he ask? What are the options left? Type 2B intermediate risk and type 2B low risk. What is our answer? Low risk is for a clean base ulcer, which is class 3, and for just black dots, which is 2C. These two come under low risk. Our adherent clot comes under intermediate risk. So our answer is option B, which is type 2B and intermediate risk. Again, remember the name of the classification, which is Forrest classification. So let's proceed on to the next question. A 50-year-old male presents with the complaints of fever, cough with expectoration. So there's fever, there's cough with expectoration. On examination, there is wheeze present. Wheezing is present. CT shows a coin-shaped lesion. Okay, what did he give on CT? A coin-shaped lesion. An X-ray image is given below. What is this X-ray? It's showing this. Yes, calcification, opacity is present. Yes, you have your opacity here. This type of similar finding is seen in radiographs in all of the following conditions except. So he is not asking diagnosis, he is not asking the management. You just need to identify what is given on this X-ray image and the conditions with similar finding. Type of similar finding is seen in all conditions except. Again, except. So what is this? This is your classic popcorn calcification. Popcorn calcification. So where is this popcorn calcification seen in? You just remember it, the mnemonic as PFC. You know the KFC, no? Just remember it as PFC. So P is for what? You see it in your pulmonary hematoma. Pulmonary hematoma. F is for fibroadenoma. F is for your fibroadenoma. And C is for two conditions, which is chondrosarcoma, which are your chondrosarcoma and your cavernous hemangioma. So these are all the conditions where you see popcorn shaped calcifications. So see, this is your chondrosarcoma where you have this popcorn shaped calcification, and this is your mammography finding of fibroadenoma where you have this popcorn shaped calcification. And here you remember, where do you see the microcalcifications? Microcalcifications indicates breast carcinoma, whereas popcorn shaped calcification indicates fibroadenoma. Okay, and this is your cavernous hemangioma where you see it in your brain, popcorn shaped calcification in your brain. So remember the mnemonic PFC for popcorn calcification. Okay, so pulmonary hematoma, yes. Fibroadenoma breast, yes. Chondrosarcoma, yes. Miliary TB of lung. Miliary TB, you have this mottled appearance of the lung, but not your popcorn calcification. So this is false option and this is our answer. Okay, moving on to the next question, and this is the last question for the session. So yeah, a 22-year male who went to a party the previous night is brought to emergency room. So he attended a party and he came to the emergency room with complaints of retching sensation. So there's this irritating sensation and this burning sensation in the chest, and had brown colored vomitus. So how is the vomitus? It's brown colored vomitus. Probably hematemesis. What is the true statement? So what is this all pointing out towards? He went to a party. He probably had this alcohol binge, which led to this retching sensation in the heart, and due to that this brown colored hematemesis, which is the ground coffee appearance of the vomitus. Coffee ground appearance of the vomitus. So what is the true statement? This is what your classic Mallory-Weiss tear. This is nothing but due to the binge alcohol and the irritation, it causes a partial thickness tear in the this just below the esophagogastric junction. You have your esophagus and the gastric junction, and just below the junction there is this partial thickness tear. So this partial thickness tear is just involving the mucosa and the submucosa. The whole of the muscularis is not involved. So there is no perforation here, just the bleeding is present, which comes out as this coffee ground vomiting. So our diagnosis is the Mallory-Weiss tear. Yes. So this is what is he saying? He's asking the true statement. Option A is, it is a full thickness tear involving the cardia. So which is a full thickness tear? You have to differentiate Mallory-Weiss tear from a Boerhaave syndrome. Boerhaave is what? Your full thickness tear. This leads to perforation. Like muscularis is also involved, the perforation, and the patient may go into a shock-like condition. But here this is a partial thickness. So this is a wrong option. Option B, left gastric artery is more commonly involved. So what is the artery supplying here? It is your left gastric artery, which is the branch of the celiac trunk, which is a branch of again your aorta. So this left gastric artery is more commonly involved while this partial tear has occurred. So this is the correct option. And what is this option C? Esophagography with gastrographin contrast. What is this gastrographin? This is your water soluble contrast. You can get a question from these contrasts as well, which is water soluble, which is not, like that. Gastrographin is a water soluble contrast. This is used in case of this Boerhaave syndrome. As there is perforation, you'll put this dye, and if there is leakage of this dye, then it is confirmatory for the Boerhaave syndrome. So esophagography with gastrographin is confirmatory for Boerhaave syndrome. So this is a a wrong option. So what is the final option? Emergency surgical intervention is required. Emergency surgical intervention is also required for both halves because it is a perforatory condition. So this is also a wrong option. Mallory-Weiss tear can be managed just conservatively, just rest and PPIs and those. So what is our answer? Answer is option B, left gastric artery is more commonly involved as it supplies along the lesser curvature. So I hope everything is clear. If you have any doubts, just put it in the chat box below so that I can answer. And yeah, this is it for today's session. You can check on the timetable again from this video so that you'll have a clarity on what classes are going to be held at what time. You can also go to the Medicoz Community website where you can avail this early bird offer for your 2024 next exam prep. Yeah, so this is it for today. Thank you.